So good morning, everyone. I'm glad I could be your guinea pig for this video recording here today. So the title of my talk is quite simply Intralipid. So even though it's a simple talk, I hope by the end of it you'll gain some appreciation as to some of the complexities surrounding this very simple drug. So just to touch up on the objectives that I sent to the office that was then sent to you. The first thing we'll talk about is the history behind intralipid use in local anesthetic toxicity, particularly in bupivacaine toxicity. And we'll talk about the postulated mechanisms of action of intralipid as it pertains to reversal of bupivacaine-induced cardiac toxicity. Lastly, we'll touch on some other uses for intralipid besides in local anesthetic toxicity. And in that portion of the talk, I'll be talking to you a little bit about my research that I'm currently doing. So first of all, what is intralipid? As most of you know, its uses in total parenteral nutrition. It primarily consists of soybean oil, and that's the major constituent of the solution. It also contains egg yolk phospholipids, or phosphatide, which enables it to have a polar structure so that it can exist in an aqueous solution. It also has glycerol to maintain osmolarity of the solution, and then water and sodium hydroxide for pH adjustment. So these are all the main fatty acids that are present in soybean oil, and the order in which they're most abundant starts at the top and goes down. So this is just to show you that soybean oil is basically a multitude of different fatty acids. Egg phosphatide, on the other hand, as I mentioned, gives it that ability to exist in aqueous solution because it has a charged structure where it has a hydrophobic area that interacts with the fatty acids, and then a polar area which interacts with the aqueous solution. So some of you may have seen this cover of anesthesiology back in the summer of last year. Basically what it depicts here is the use of lipid emulsion as a lifeline in a variety of patient care settings, not only in the operating room where we're primarily involved in, but also in the emergency department, the intensive care unit, and difficult to see there, but that's the outpatient setting as well. So now I'd just like to shift gears a little bit and talk to you about local anesthetic toxicity. So just to get some, I guess, information more so for the junior residents in the audience here. The earliest clinical manifestations of local anesthetic toxicity include lightheadedness, altered mentation, agitation, you get a slurred speech, and visual disturbance. And early change in vital signs include tachycardia and hypertension, which then ultimately will lead to hypotension. And in severe toxicity, what you classically see is CNS excitation with cardiac arrhythmias, conduction blockade, and contractile depression, again leading to the hypotensive response. Now, the dose required for a cardiovascular collapse is greater for all anesthetics than it is for CNS excitation. The ratio for lidocaine is 7, and the ratio for bupivacaine is 3. So why is the ratio lower for bupivacaine? It's because it has higher lipophilicity and potency than lidocaine. So therefore, you can have bupivacaine toxicity leading to cardiovascular collapse without really seeing CNS symptoms. Now, specifically for bupivacaine toxicity, what you'll see is hypotension and bradycardia that quickly leads to malignant ventricular arrhythmias and cardiovascular collapse. Now, this kind of cardiovascular collapse is highly resistant to standard resuscitation, your standard BLS and ACLS protocols. And most recommended drugs are supportive, so sympathomimetics and amiodarone for its antidysrhythmic properties. Beta blockers, calcium channel blockers, and for obvious reasons, local anesthetics for rhythm disturbances are considered contraindicated in someone who has suspected bupivacaine toxicity. So the mechanisms of bupivacaine toxicity are numerous. They can involve basically these 3 types of mechanisms. So the ionotropic mechanism, not to be confused with inotropic mechanism, this relates to the function of ion channels or ligand-gated ion channels. Metabotropic mechanisms refers to the second messenger systems, the G proteins that we all remember from our undergrad days. And lastly, energy transduction systems. So the metabolism of the cardiomyocyte to ultimately to generation of ATP. So to talk about the inotropic and metabotropic mechanisms, this slide here just basically tells you some of the ways that bupivacaine can cause toxicity. So you may have heard of the fast and slow out model for bupivacaine binding to sodium channels. Basically, you get a quick inhibition of the sodium channels, but a slow dissociation from the channel, so therefore you get this prolonged activation leading to an inactivation of the sodium channel, and therefore you don't get the actual potential response that you require. But bupivacaine also alters excitation contraction coupling, calcium release and sensitivity, potassium channel signaling, as well as beta receptor signaling. Now, I want to just talk to you about energy transduction systems because this will become more clear later on in the talk. So if you remember back from your biochemistry days, there are a couple of ways that the cardiomyocyte is able to gain its ATP. The first method here is fatty acid oxidation, and the second is glucose oxidation, again ultimately leading to the Krebs cycle and giving us ATP. The reason why these are circled in different colors and this one here is bolded is because the fatty oxidation pathway is the primary way that cardiomyocytes are able to get their ATP. And if this side here is knocked out, then it goes to a glucose oxidation pathway, but the generation of ATP isn't as robust as it is with fatty acid oxidation, where you can have a great throughput to get a lot of ATP. So in terms of the energy transduction systems, bupivacaine is a classic uncoupler of oxidative phosphorylation, so the step at which you get ATP with aerobic metabolism. With that being said, there are some other mechanisms that you'll see here in the next few slides. But first I want to bring up a name here, Guy Weinberg. So who is he? Dr. Weinberg is an anesthesiologist in Chicago. He has an interest in lipid reversal local anesthetic toxicity, and he founded the site lipidrescue.org, which gave a sort of a recommendation for lipid resuscitation, which a lot of us are familiar with. So his observation was actually something in the mid-1990s. It was a chance observation while he was studying metabolic effects of bupivacaine, because this was one of his interests in research. And he further refined that study and did this study that was published in Anesthesiology in 1998. And what he found was that in rats who were given a bolus of bupivacaine, a lipid-based resuscitation was far superior to just to the rats given saline as a volume control, essentially. And down here in the graph, what you can see here on the y-axis is mortality fraction, and on the x-axis is bupivacaine bolus dose. And in the white is lipid treated, and the black filled circles are saline treated. And what you can see is there's the shift of the lethal dose of bupivacaine shifted to the right. So he further refined that study and did a study with dogs in vivo. And what he did was a large dose bupivacaine bolus was given. And what you can see here in this graph is blood pressure here on the y-axis and time on the x-axis. And I labeled these different points here as points of intervention. So these dogs were given bupivacaine, so you could see this blood pressure here. Looks like the systolic is probably around 100, 110, and the diastolic probably around 70 or 60. Once that bupivacaine is given, then you get this hypotensive response. They were given then manual cardiac massage, which generates some pressure, as you can see here. And they were given lipid after that, and then you could see this return of blood pressure to the point where it was sustained. And because these dogs then restored their hemodynamics, just to make sure that they were still anesthetized, they turned on isoflurane again before they euthanized the animal. But you can see that with lipid resuscitation, that the blood pressure stayed pretty much at its baseline. So what about the mechanisms? So so Dr. Weinberg and others have gone on to look at some of the mechanisms involved, and one of the ways to study the mechanism is with the isolated heart perfusion system. This is something that I'm actually not too familiar with, so I had to look it up, and it's not a technique that I use. But basically, what the gist of it is the heart gets isolated from an experimental animal, and then it's isolated, hence the isolated heart perfusion system. There's a perfusate here which contains nutrients, oxygen, etc. That then gets fed into a cannulated aorta and allows that perfusate to go through the coronary arteries to allow for delivery to the myocardium. And then there's also a balloon here that's inserted in the left ventricle, which is connected to a pressure transducer, which then is connected to a computer, and then you're able to get essentially the tracings of cardiac function from that. And so this is what Dr. Weinberg found in 2006. So just to show you his infusion protocol, so this is an isolated rat hearts. He gave a bolus dose of bupivacaine followed by a continuous infusion of Intralipid, again through that perfusate that I mentioned. On the left side here is basically saline. So after the bupivacaine bolus is saline, and then on the right here is lipid. The first panel here shows you left ventricular pressure tracing. On the second panel here shows you heart rate, and down here is something called the rate pressure product, which is the pulse pressure times the heart rate, and it's a good indicator of cardiac function or cardiac work. And what you can see here is that the time to first beat was significantly sooner for the lipid-treated group, and the time to 90% of the rate pressure product was also significantly faster with the lipid-treated group, suggesting that lipid returns cardiac function quicker than if you don't give lipid. One way to determine if extraction of bupivacaine played a role in these isolated hearts, what they did was at different time points, they took little bites of the myocardium, and they were able to determine the bupivacaine concentration. And what you can see here is the difference between control and lipid. The time that bupivacaine left the myocardium was quicker than it was in the lipid group than it was for the control group. So therefore, they concluded that Intralipid reverses bupivacaine toxicity by acting as a plasma phase lipid sink, so basically extraction of the lipid from the cardiac tissue. However, they did comment that the rescue in vivo occurred more rapidly than could be explained by bulk extraction, because bupivacaine would have to cross several tissue barriers to get into equilibrium. So they suggested possibly that Intralipid enters cardiomyocytes and inhibits bupivacaine-induced toxicity. So they suggest that an additional or alternative mechanism might exist that may explain that. And just to touch on this alternative mechanism, I want to talk to you about one of his other observations, and this was a case report that was published in 1997. Basically, a patient who had isovaleric acidemia, so and I had to look that up. It's basically someone with inborn error for metabolism of proteins, specifically leucine, and they get this accumulation of isovaleric acid. And this patient received a subcutaneous bupivacaine dose of 0.37 milligrams per kilogram, and they had ECG changes leading, and as well as hypotension. And in this paper, they suggested that it was because of carnitine deficiency that can happen with people with isovaleric acidemia. So what's the big deal with carnitine deficiency? Well, carnitine is important for fatty acid transport into the cardiomyocyte mitochondria. It's as I mentioned, the fatty acid oxidation pathway is the preferred way that the cardiomyocytes get their ATP. Deficiency in carnitine may therefore result in decreased fatty acid substrate, and therefore a shift towards the glucose oxidation with whatever remaining fatty acid substrate that the cardiomyocytes are able to get. And Weinberg, after that study, actually looked at cardiomyocyte mitochondria and found that bupivacaine inhibits fatty acid transport. So in a patient who has isovaleric acidemia, who has already this minimum functioning fatty acid transport system, if you further inhibit that, then that could result in that cardiovascular collapse that we saw in that case report. At least that was their suggestion. So that theory from that point, therefore, is that Intralipid reinstates fatty acid cardiac metabolism. So the question is, does it reverse the inhibition of fatty acid transport? Or, because as you saw earlier, Intralipid primarily consists of fatty acids, does it provide fatty acid substrate to the cardiomyocyte? And that's one of the thoughts that's floating around as well. Primarily because in the study in 1989, it was shown that bupivacaine-induced cardiac depression was actually restored with ATP. So it suggests to you that aerobic respiration is an important clinical target for people that have bupivacaine-induced cardiac toxicity. So based on all that data that was published in the basic science literature, lipid emulsion has been used in sort of the nothing-to-lose situations. The very first case report was published in 2006 in anesthesiology, and it was for a patient who had a successful resuscitation with Intralipid following what was presumed to be bupivacaine-induced toxicity from a regional anesthesia procedure. Subsequently, another case report was published in 2006. This time it was Intralipid use in ropivacaine toxicity. And the May 2008 issue is actually dedicated to local anesthetic toxicity, and in that issue there were also 3 other successful reports of reversal of resuscitation with Intralipid therapy. So now I'd like to talk to you about some of the uses besides local anesthetic toxicity. So the first one here, the first set here that I want to talk to you about are ones that were done in animal models. Again, talk to you about Dr. Weinberg's study. Those were all started at the bench in the basic science level, and what this group found was, this very first group here, 2008, they found that Intralipid improved propranolol-induced toxicity in rabbits, and they followed up that study by looking at metoprolol, but they found that it did not improve metoprolol-induced toxicity. And the comment that they had between these 2 beta blockers was that propranolol is more lipophilic than metoprolol is, and they suggest that's the reason why Intralipid was able to work in that situation, again attributing it to the lipid sink theory. It also restores blood pressure, improves survival in verapamil toxicity in dogs, and that was a study published in 2007, and also it improves hemodynamic recovery and clomipramine toxicity in rabbits. So now looking at some of the case reports, besides local anesthetic toxicity, the first one here that I present to you is this one case report looking at someone who tried to commit suicide with using bupropion and lamotrigine, and basically gave himself an overdose. When you read through that case report, what you'll see is that this patient was given 1 hour's worth of ACLS resuscitation, and that wasn't working. And then they gave Intralipid, and within 1 minute, there was a return of spontaneous circulation. So, and this patient survived after that ordeal. Another case report, which was published, I think, out of China or Korea, I can't remember, was someone who also tried to commit suicide by ingesting glyphosate surfactant herbicide. And for this patient, they were brought to the emergency department and subsequently to the ICU. And this patient had refractory hypotension despite being on inotropes and vasopressors. And ultimately, they were given Intralipid, and it improved their refractory hypotension to the point where they didn't need inotropes or vasopressors anymore, and a return of level of consciousness to the point where he was able to self-extubate himself and leave the hospital AMA.
Drink more.
So another one is following the tricyclic antidepressant dosulipin overdose. Again, the psychiatric world where someone's trying to commit suicide, they found that there were ECG changes essentially that was sort of preempting a cardiovascular collapse. So someone thought, well, let's, before anything gets worse, let's give Intralipid a try. And what they found was that the ECG changes, which consisted of wide QRS and long QT, improved with Intralipid treatment. Another case report here was haloperidol, the antipsychotic. This was for a patient who had 13 minutes of ACLS protocol for pulseless electrical activity. Intralipid was given, and then 2 minutes later there was a spontaneous return of circulation and improved level of consciousness. And again, this patient who was obtunded during the resuscitation then was combative, and after that, resuscitation required sedation. And finally, a case report here was recently published, looking at someone who had a quetiapine and sertraline overdose. Again, improved hemodynamics in that patient and a return of level of consciousness. Okay, so now I'd like to spend the last little bit here, I think we're going to finish early actually, talking to you about some of the current research that I've been doing, or I could title that slide what I've been doing during my off-clinical time. So some of this, actually most of this data will be presented actually next week at the IARS annual meeting, as well as at the CS, both as poster presentations. And I'd also like to preface this part of the talk by giving you a little bit of background as to how it came up. So back in 2008, I had this conversation with Ben because there was that issue in anesthesia and analgesia talking about mechanisms of action of Intralipid and bupivacaine toxicity and the lipid sink theory, etc. And 2008 was also the year that I was starting my my research, looking at propofol and vascular function. And when we were talking about it, we discussed, bupivacaine is quite lipophilic. Intralipid works for that. What about other lipophilic substances? And he said, well, you're using propofol, aren't you? I said, well, yeah. And he said, well, why don't you just take some Intralipid at the end of your experiment and throw it in there and see what happens? Like, sure, why not? Let's give that a try. So that's sort of how it all started, and then it culminated in, ultimately into what I'll present to you here. So I'll just give you a little bit of background as to some of the experimental techniques that I've been using. So the first one here is a wire myograph. Basically what we do is we get very small arteries, isolate them and put them in a tissue bath, which is connected to a force transducer. This force transducer is then able to measure differences in tension or changes in tension to various physiological, pharmacologic stimuli. The signals from the force transducer then go to this analog to digital converter and ultimately to a digital recording on a computer screen, which we're then able to analyze. And just to give you sort of a close-up view of what that tissue bath looks like, we have an artery that's typically dissected about 100 to 200 microns and mounted in this tissue bath. Again, the wires are connected to a force transducer, and then I add drugs to the bath, in this case propofol, and then I measure relaxation. So this is basically some of the preliminary work that we had published as a letter at the CJA in 2009. So I'll just walk you through some of these curves here. So what you can see here, these are just raw tracings of what happens when we give propofol and Intralipid to this blood vessel. So following phenylephrine constriction, we were able to induce, so basically on the y-axis here is tension. By increasing tension by giving phenylephrine that is causing constriction, we added propofol, and you can see this reduction in tension, which translates to vasodilation. And you can see that above and below here in the blue and the green. So above, we added Intralipid, and you can see this return of vascular tone back up to essentially baseline. And on the bottom here, we use the same volume of saline, and you just see this little blip, but no return of vascular tone. When we compiled our data, again, this was a very small preliminary study, it was an N of 4, but you could see that there was a clear difference between intralipid and saline control in reversal of propofol-induced vasodilation. So that's basically how it all started. Once we had this published, then we continued on with more studies. So the first question I had was, what about the dose of intralipid? Again, because we had nowhere to fall back on, this hasn't been done before. I had no idea what dose would be relevant, so to say. Just looking at the dose here, it was quite high, 2% in the tissue bath. You're starting off with a 28% solution, so it's not really diluting it down. So I then trialed fairly small doses, 0.002 and 0.2%. That being said, when I started this work, there was a paper that was published in Anesthesiology in 2011 or 2012. So after I started doing this work, that actually published, again, similar, using the same animal model as me, looking at vascular function, but instead of propofol, they were looking at bupivacaine and vascular function. The doses that they used, and they had it published, was actually, the low range was 0.2, and the high range was 1.4. So you can see that this dose is actually quite substantially lower than that which has been published. That being said, this is what we see with the fairly low dose that I'm using. So on the left here is the cumulative data in dose response in a dose response curve, and on the right here is all that data that's accumulated as area under the curve, just to summarize that data. So the y-axis here is percent reversal of propofol relaxation, and the x-axis is increasing doses of intralipid. And what you can see here is there's intralipid and DMSO. The reason why I did DMSO is because DMSO is also a substance that readily solubilizes propofol. So again, looking at the lipid sink theory, if that truly is what's happening, if you're giving DMSO, then theoretically it should reverse that relaxation as well. But that's not quite what you see here, because you can see that there's a significant increase in reversal of relaxation in the intralipid group compared to the DMSO group. And looking at intralipid by itself, you can see that there's on the y-axis here is percent of the phenylephrine constriction. So when there's no constriction given at all, when we just give intralipid to the bath, you can see essentially a flat line, which means that intralipid does not cause any constriction by itself. Whether or not, if we go back here, whether or not this return of vascular tone is because intralipid is potentiating the actions of phenylephrine. What you can see here is that, again, you don't have this increase in constriction. In fact, you actually see a bit of a decrease in function there, which suggests that you're getting some vasodilation with intralipid, which has been reported in the literature before. Next, I wanted to look at the difference between aged and young, because my primary interest in research was looking at the aging vasculature. And again, this is percent reversal of propofol relaxation with increasing doses of intralipid. Yellow is aged, and white is young. And in these series of experiments, I also did time control just to determine whether or not just giving it time actually reversed propofol-induced vasodilation. I'll just take you over to the area under the curve data here on the right. And what you could see here in the young is that there was no significant difference between the intralipid and the time control group, its respective time control group. But in the aged, you can see that there's a significant reversal of propofol-induced vasodilation in the intralipid group compared to the time control. When we compared aged to young, you can see that there is also a significantly increased reversal in the aged compared to the young. So all that was the ex vivo data, the data that I collected from isolated small arteries and put them in tissue baths. So the take-home message from that is that intralipid significantly reverses propofol-induced relaxation arteries from aging rats compared to young rats. But the big question I had after that was, does reversal of propofol-induced vasodilation translate to reversal of propofol-induced hypotension in vivo? So the hypothesis I had then at that point was intralipid in the in vivo setting will correct hypotension associated with propofol use in aging rats. So for this experimental design, what I did was had the rats aged 14 to 16 months. They were given a tracheostomy for mechanical ventilation, and continuous blood pressure was monitored through abdominal aortic cannulation. IV access was established to the femoral vein for drug delivery. In that situation, we gave propofol, and then we gave Intralipid, basically the equivalent volume of propofol times 4. So 4 successive times you would give the same volume of Intralipid as you would for propofol. And we did the same thing for normal saline. Again, the same volume of propofol we would give as saline, and that would serve as our volume control. And then we also checked to see if Intralipid would reverse hydralazine-induced hypotension as well. So the first thing that we noticed was that between the aged male and female, there was no significant difference in the reduction of blood pressure when we gave them propofol. However, there was a differential response when you look at the reversal of hypotension by Intralipid. So on the y-axis here is percent reversal of mean arterial pressure reduction by propofol, and on the x-axis is increasing doses of Intralipid. The blue is male and the pink is female, and on the right is the summarized data as area under the curve. And what you can see here is that in aged male, there is significantly greater reversal of hypotension caused by propofol compared to the aging female. That being said, I just want to draw your attention to the fact that in the females, we were able to achieve essentially a 100% reversal of the propofol with propofol hypotension with Intralipid in the females. And in the males, we were able to achieve almost a 200% reversal, which is substantially greater response than we expected to see. And essentially 100% was gained probably about the second dose of Intralipid there. So when we looked to determine whether or not volume played a role in this, on the left side here we have the aged female, and on the right we have aged male. Insets are area under the curve, and what you can see here is that in both female and male, there's significantly reversed hypotension with the Intralipid group compared to the saline. So it suggests to you that volume is not the key player in that reversal of hypotension. Intralipid does not reverse hydralazine-induced hypotension. Again, aged female on the left, aged male on the right. Area under the curve, you can see that there's substantially greater reversal of propofol-induced hypotension compared to hydralazine-induced hypotension in both the aged female and aged male. And next, we looked at causing hypotension with increasing dose of isoflurane. Essentially, what I did was I turned the isoflurane concentration to 5%, and you can see that the reversal of propofol in both the female and male. Reversal of propofol-induced hypotension is greater than it is for isoflurane-induced hypotension. I mean, you're still getting a response here, 50% essentially in both groups, but it's not as great as that seen with propofol. So another interesting thing that we found was if we pre-treat these rats with Intralipid, so basically what we gave them was 2 times the dose of propofol that we were intending to give them, we found that at the 5-minute mark, there was essentially no hypotension in the pre-treated Intralipid group, whereas in the group that was not given Intralipid 5 minutes after the propofol is given, they don't get their blood pressure back. And oftentimes, if you just let it ride, they don't gain their blood pressure back. I don't know how long that would go for, but that'd be something interesting to find out, I guess. And finally, Intralipid by itself, when we give it to these rats, does not increase blood pressure to the same extent as following propofol. So basically what we did for these experiments were these rats were they're cannulated, and we would just give them Intralipid, and you would get this little increase in blood pressure. However, if you look at the groups that had propofol given to them, the actual absolute increase in blood pressure was substantially higher in those rats given propofol. So just to summarize those findings, Intralipid restores blood pressure following propofol administration in aging rats. Because there's a greater response in males than in females, that the lipid sink theory doesn't fully explain those results, and I think something else is going on here. What it is, I don't know yet. The response isn't due to an increased intravascular volume. Intralipid doesn't restore blood pressure following hydralazine administration, suggesting that it doesn't cause basically direct vasoconstriction. That being said, hydralazine may be blocking sort of the downstream pathway at which intralipid is working, which is why we don't see that increase in blood pressure. And lastly, intralipid doesn't acutely increase blood pressure in the absence of propofol. So the conclusions from the study so far is that intralipid has a selective interaction with propofol and may potentially be used to maintain intraoperative hemodynamics in the aging population. So the big question I have is, can intralipid therefore be used besides resuscitation following cardiovascular collapse? So something as a mainstay of almost, like, I'm thinking daily use, if you want to use it in someone who's given propofol and they get this substantial decrease in blood pressure. So the future directions from where I'm going from here, which I hope to achieve over the next few years. The first big question is the mechanism of action. How is it working? How is it interacting with propofol? And once we come up with that mechanism, that can take us to this final future direction here. The second one is, does intralipid interfere with propofol's anesthetic effects? So besides the hemodynamic effects, does it alter depth of anesthesia? And I actually have spoken with Francois, who's an electrophysiologist who does scoliosis surgery, and he's actually on board with this, and he's happy to get involved with this study since he did his PhD and did some basic science work in animals. And he said he's able to make some EEG electrodes for rats, so we'd be able to do that. And then ultimately, in the scoliosis surgery, because we do use TIVA, I'm thinking that in the future, of course I have to go through ethics, but giving a single bolus of propofol just to determine what would happen to the EEG tracing that the electrophysiologists are looking at, just to see if the burst suppression is decreased with your administration of intralipid. And finally, after we answer these two sort of questions, can intralipid be used clinically to restore hemodynamics after propofol use? So again, that's sort of the final step after coming up with these two answers. So now I made it seem like lipid was a fantastic drug, but there are some complications that are associated, so I just thought I'd end off my talk with some of the complications. Generally, it is well tolerated at 5 to 10 mils per kilo per day, but it is known to modulate cytokine production, and it could or increase your risk of infection. It can cause thrombophlebitis, which is the reason why they suggest that it be administered through a central line. It could impair the reticuloendothelial system and alter inflammatory response. And this happens after long-term exposure to intralipid. So people who are on intralipid for days and days. And obviously, because the major constituent of intralipid is soy, if you have a soy allergy or anaphylactic reaction to soy, then you shouldn't have it. You can get fat emboli if you have your micelles larger than 5 microns. Pulmonary hypertension can occur as well, but again, that's only suggested if intralipid is given at a fairly high dose over a long period of time. It can cause coumadin resistance because it facilitates coumadin binding to albumin. It can interfere with ECMO. It could induce weakness, altered mentation, and seizures, at least in the pediatric literature. And it could increase intracranial pressure after traumatic brain injury. And this was all stuff taken out of Ethical in 2008. So that being said, that's the end of the talk. I'd be happy to field any questions if there are any. Yes?
I was curious in the in vivo rat model with males having a 200% return in the blood pressure versus a female just kind of normalizing. When they're trached and cannulated, are they given other sedations or other?
Yeah, they're maintained on 1.5% inspired isoflurane, and that's just to ensure that they're still anesthetized. And basically what I do is I anesthetize them with 3 to 5% by a mask once they're trached, and I close off their trachea, and then essentially a closed system, at least at the airways. So I turned them down to 1.5%, and essentially at that concentration, they're still anesthetized. Typically what we look for is like sort of a writing reflex, like they try to move if they aren't anesthetized, but none of these rats would move at all with the 1.5%. So they were maintained on 1.5% baseline and equilibrated for about 15 to 20 minutes so that the blood pressure gets stable, and then we would administer our propofol bolus.
So why do you think the males had a above baseline return of blood went to 200%?
I have no idea. I'm thinking, just looking at some of the literature outside of anesthesia, there's some suggestion that intralipid increases sympathetic activation. So, I mean, it could be that intrinsically sympathetics are getting activated, and this could be in combination with what's happening at the vascular level, since what we saw at the vascular level was isolated with no sympathetic response at all involved in those series of experiments. That being said, I do have data on heart rates, and heart rates did increase. By the end of the lipid bolus, what they would get was about 110% of their baseline heart rate for the males, and in the females they were about 100%. Now whether or not that 10% differential translates to a 200%, I couldn't tell you.
Thanks, man.
Is there any data on using intralipid to treat propofol infusion syndrome?
No, actually there wasn't anything on that, and again, there's other than the study that I had published in the CGA, there's no paper out there talking about intralipid, like potential reversal of propofol, anything. So, mind you, I haven't looked for a few months. Maybe something has come up, but that would be something interesting to look at as well. Actually, something that a colleague of mine had mentioned was for the patients who have TIVA for these long scoliosis surgeries, or for your neurosurgical procedures where they need to be crisp and awake immediately after, just to assess their neurological function. I mean, sure, there's the TIVA programs that we can use, but if there's something that we can, I don't know if it would have an effect on awareness or emergence from anesthesia, but if that's something that could be further on down the road, that may be sort of an exciting avenue to explore. Davey, yeah.
What we use in the OR is 1% propofol and 99% intralipid, right?
Yeah.
So I mean, why aren't we seeing? So what you're postulating then is the clinical effect, the clinical hemodynamic effects we see from propofol are sufficiently intense that they override the 99% effect of the intralipid, and you're looking for an additional effect, more intralipid. I mean, does that seem plausible?
Well, to be honest, I don't know what's happening from that perspective, because the propofol I was using was actually Diprovan, because we can get pure propofol from the companies and do experiments that way, but I thought, might as well keep it clinically relevant as you can with rats. And I injected these rats with our clinical propofol, and then I gave the intralipid, and that's the response I saw. So I can't comment more on that. I mean, I did contact Dr. Baker down in California, who's sort of the guru in propofol formulation and that sort of thing, and he said that propofol itself is made with intralipid. Like, you can't get pure propofol and get intralipid and mix it up yourself. It's actually manufactured in a way where it gets placed in mice cells, and then the intralipid is sort of formed around it. So once you give your propofol to a patient, then you get this dissociation of that interaction, and then your propofol is free to bind. Whether or not the formulation of the propofol and intralipid and the way that it's made alters the way that intralipid is working, I can't tell you that either. But all I can comment on is what I found with these results, which to me is exciting, but to others, not so much. So.
That's interesting, because I was just thinking when you were making that comment that if you could get the pure propofol and then mix up your own formulation that mimics Diprovan, then you could isolate whether there's a difference between the way that they create it and the fresh intralipid that you would have Have you given any thought to maybe studying the effect that you may have with propofol in patients who are coming from, say, ICU or getting TPN, who have intralipid infusions already going?
Well, that's a good
clinically applied, right?
That's a good point, actually, because, well, I guess anecdotally speaking, like my N of 2, maybe it's because it's something that I wanted to see. But when I was doing endoscopy down here at the U, I had patients on TPN and had the intralipid running, and I basically run I give them a little bolus of propofol, then I run an infusion, and I kept the regimen the same for pretty much most of the day, including this patient who is on TPN, and at least maybe it's something I wanted to see, but I didn't see as much of a hemodynamic fluctuation with with those patients than what I did with the other patients that required me to give them some ephedrine or phenylephrine just to bring up their blood pressure during their procedure. So again, that's something that we'd have to look at later on down the road again. I suspect that we would have to sort of come up with plausible mechanisms, and determine whether or not there's an effect on awareness before we can go forth with a study like that, even though we are giving propofol to patients who are on intralipid already. And the patients I gave the propofol to, they didn't seem to have any alteration of anesthetic effects of propofol in terms of awareness during procedure and that sort of thing, at least when I asked them afterwards.
Do you think that the intralipid mixed with Diprivan is preventing us from having catastrophic consequences right now? And is it modulating if you use pure Diprivan, you get a much more profound effect than if you use the stuff that we use clinically? Possibly,
but I think that if you were to try to give someone propofol, it just wouldn't really. Just because propofol itself is, if you look at the pure solution, it's basically like an oil, yeah. And I think if you give it to someone, it just wouldn't have the same effect that it would in its already clinical used form. But that's a good thought. I don't know if it would make a difference in terms of hemodynamics. Yeah, Derek.
I think it was about, as you pointed out, 8 years from when Weinberg first published his canine studies to when Meg Rosenblatt published her case report. And then the next 2 or 3 years after that, I remember that she literally opened the floodgates. Mm-hmm. Every month there was a new case report describing the successful use of intralipid in every single block that we could think of in both peds and adults for every concentration of local anesthetic. Mm-hmm. I've yet to see a description of the unsuccessful use of intralipid. Have you come across that at all?
I haven't, but I suspect that people who have an unsuccessful use of intralipid probably don't submit it for publication.
It would be useful to see that.
It would be, but I suspect that that's the reason why. It's just like the same thing with getting negative data. We get negative data, we try to submit it for publication, and they say no because it doesn't really, at least to the editor's eyes, doesn't really add to the breadth of knowledge that you need. But negative data is also good data in my eyes. And like you said, if they had a negative outcome from intralipid use, then I think that would be important to get published as well.
There is one, actually. There was a residence competition a couple of years ago at the CAS, and it was really disappointing to me because I think it might even have won. What they did in pigs and found didn't work.
Was that the one with asphyxia?
I don't think so. I mean, I just, well, what they did was they, tried to recover pigs after overdoses of local anesthetic. And it was hugely disappointing to me because it looked like this was going to be a thing. But that's the one negative one and I think that came second or maybe even won, about 5 or 6 years ago at the CAS.
Okay.
I don't know if that was ever published or not. I don't know.
There's an editorial in one of the recent Australian journals suggesting that this whole intralipid thing's overblown, mm-hmm. and that you have to be more highly selective. And they suggest that giving things like bicarb are equally as efficient for treating tricyclic overdoses and other ones other than the local anesthetic. So it seems like the pendulum might be swinging a little bit.
Yeah, I think so. And the other thing I forgot to mention as well is the dose that, so not only the concentrations that I've used in the tissue bath experiments, but also the doses I've used in vivo compared to the other in vivo studies that they've looked at with looking at resuscitation. They were giving in the range of about 10 to 15 mils per kilo of intralipid to get the response. Whereas for me, I was going from 1 to 4 mils per kilo. So it was, again, a substantially lower dose than what they've used in their models, including rats. Like, I don't know, I really do think that this could be something that may potentially be used, like instead of using the 100 mils that you would for resuscitation, just giving someone 10 mils of intralipid just to see what that would do with hypotension that occurs with propofol. I mean, of course, we've got our emergency drugs, or ephedrine, or epinephrine, or phenylephrine, but this could just be something in addition to that. Or what if intralipid actually potentiates the effects of phenylephrine, for instance, where you just give them 100 mics instead of 200, and then you get the same response.
Yeah, but at least right now, given 10 mils in a resuscitation mode when you've done CPR for 20 minutes is a little gamey, at least at this early juncture. Right?
Yeah.
So, I mean, people are trying to standardize at least a treatment protocol.
Yeah, again, but this work isn't really looking at resuscitation. It's looking at something that could potentially be used sort of in a everyday scenario. Whether or not it gets accepted, I don't know, but that's my hope anyway.
Do you have any idea, Ferrante, about the time course on giving a bolus of intralipid following marcaine toxicity? How long should you keep them and watch them for? They're all tingly and whatever, have a convulsion. You give them the dose of intralipid, they come right, then what?
I can't comment on that. I don't know the
For
literature that
local
well.
anesthetic toxicity, it's on the ASER website.
Is it? How long do you have to watch them for?
You keep it going for up to 24 hours.
As an infusion, always?
As an infusion.
Always?
Yeah. With a real local anesthetic toxicity,
Yeah.
I think, as an observation, we've probably used intralipid here 5 times or less. I'm not sure it was required on one of those occasions. But for a...
There are 10 minutes remaining in this video conference session.
You keep that infusion going.
So you give them one dose, they come right, you can't just...
Sometimes you need to give them more than
Yeah,
one
but
dose.
if they do come right,
Yeah.
will the marcaine toxicity then re-manifest itself after the intralipid is gone?
Myokine?
Marcaine.
Oh,
Myokine.
Okay. Yes, it has done. There have been reports of that.
Interesting work. Thank you.